I'm Dayaris Morffi, an anesthesiology resident from the University of Michigan. I'm going to talk about a study done here on medial branch radiofrequency ablation outcomes in centralized pain patients. There is some inconsistency in the results of RFA outcome studies. The most efficacious results are seen in studies with very specific patient inclusion criteria. Our goal in this study was to examine patient factors associated with RFA failure to ultimately improve RFA outcomes. The role of centralized pain on RFA outcomes is yet to be explored. Using the 2011 fibromyalgia survey criteria as a surrogate of centralized pain, we aim to examine the association between a centralized pain phenotype and pain outcomes following RFA. We hypothesized that patients with a more centralized pain phenotype would be less likely to respond to peripherally directed spine interventions like RFA, which may partially explain a portion of the high failure rates reported for this therapy. We included patients at the University of Michigan Back and Pain Center that were scheduled for facet interventions. They completed questionnaires consisting of several validated self-report measures at their baseline visits, which were prior to the medial branch blocks, and on the day of the RFA. After the intervention, we followed the patients for 12 months. In the current analysis, the 3-month post-RFA results were our primary focus. Our statistical analyses consisted of dependent sample t-tests comparing baseline to 3-month scores and multivariable linear regression models to evaluate covariates independently associated with change in pain 3 months after RFA. Our results were that patients with higher fibromyalgia scores had less improvement in overall body pain. This profile plot shows the change in overall pain for patients positive for fibromyalgia on the left and those without fibromyalgia on the right. This profile plot shows a change in site-specific pain for patients positive for fibromyalgia and those without fibromyalgia. A total of 3 patients with pre-existing centralized pain had at least a 30% reduction in site-specific pain compared to 12 patients without centralized pain. In a secondary analysis, we assessed changes over the 3-month post-RFA period in other domains beyond pain for the entire cohort and saw statistically significant improvements in many of these parameters, including anxiety, physical function, centralized pain, overall body pain, spine pain, catastrophizing, and sleep. Although patients without baseline centralized pain exhibited more improvement in overall pain compared with subjects with centralized pain, this trend did not reach statistical significance. There was no difference between the groups in the change in spine pain. The present study was designed as a pilot and with a small sample size and was likely underpowered to fully address the study question. This finding suggests that for patients with a centralized pain phenotype, back pain was less important to their overall pain with less overall pain benefit from their RFA. Although future studies are needed, these data may have implications in patient selection for facet interventions.